society, social sciences, importance of behavior sciences. And I still remember now, there is a table after 30 years, 20 years, I can recollect the page of that where it has few concepts of cost benefit, cost utility, cost effectiveness, and their description and related to the dental examples. I really wonder at that time I was finding difficult to understand, but still, I could able to recollect that information and build on those what I had read on the book. I was fond of that book, and uh, it had so many concepts of social concept, which at that time it was for me everything was strange words, but still, that interest led to me to how important is the social sciences and behavior sciences in dental, because we always feel that what it's dental tissues are hard tissues, and how does the soft sciences came into picture. And always we wonder why for a dentist who drills and fills the cavity, and why a social science is required, or what are the different disciplines of social science, how it becomes important actually. It was again, the question mark was always there in the back of my mind. Still we were very beginners in dental public health, and always the questions arises, and difficult to get the answers, because we were needing champions, leaders in that field to understand that. So the journey went on till 2008, when I met her in Toronto in IADR conference, where she had won Louis Cohen Travel Award for the epidemiological section of IADR, where she instituted an award in her name. And I had just done my the PhD work, and I submitted my abstract to her. And fortunately, I was the first person to get the award from her, for the Louis Cohen Travel Award. And the award carries $500, and it was difficult for me to travel with that $500 to Toronto, but somehow it was my one of the best journeys to the IADR conference. And where I could meet her about, and I really was happy with that. We have still a photo with her uh, presenting that award. She started her journey in 1964, where she finished her PhD, and she came to the Washington, D.C., and looking for, it's a really mystery which we will find to know why in 1964 she started looking at dentistry as her path. Uh, and she joined in a Department of Human Health Services at US, talking about the dental health, and especially dealing with the social sciences and sociology and behavior sciences in uh, dental health. Now, uh, dentistry is basically a material science, and most of material science. And how come a non-dentist like Louis Cohen, who has never been a never, he has no acquaintance with the dentistry, but she has made a mark in every aspect of dentistry and every organization, if you look around, and she will be there. Okay, she has around 55 years of experience, and done her BA in sociology, University of Pennsylvania, sociology in masters, and PhD in sociology, and has around authored 4 books, and 150 professional journal articles, and every international organization carries her name. So these are the few things which I feel that one should able. This is the book I was trying to, um, uh, recollect, this disease prevention, oral health prevention. Uh, this is the same book which is there, which I used to read, 20 years back, and she has established this, founder member of this IADR Behavior Epidemiological and Health Services Research Group, and The emergence of social and behavior sciences in dentistry, the Louis Cohen, a principal architect. And this is a recent declaration where it was, I feel it is one of the most interesting, and sometimes it's little controversial. Because their declarations are, as we go through this interview and her discussion with her, we find is very interesting for us to understand how dentistry evolved and how future of dentistry should be there. And this is I really I had one interaction with 240 years of experience of dentistry, combining all this 6 people, and how they have chalked out a charter and made some declaration for future change in dentistry in crisis. These are the important things which I am trying to highlight. And if I will share you her CV, it takes around 45 pages and that is up to 2019. She told me that she has not updated after that. So it's it's a big thing to tell, but these are the few things which I can highlight about her achievement and how important her contribution to the dentistry and to the dental public health. And as we go through this format of in discussion with her, and we can enrich ourselves, and you can also give your questions in chat box and wait for your and there is an open session also where you can interact with her also. So what we are trying to understand with this is how a social science analyst in oral health journey she has done so far. And because we always think about data analysis or like that, a statistical analysis, but how do we do a social analysis, social science analysis in oral health, and how journey she has created for many people around the world to take that path. I also share one person here in the audience. I just got the information. Deepajit Das. He's also a recipient of our award in 2019. So I think you can raise your hand so that or you can on your video to everybody can see you also. Deepajit Das. So, Dr. Cohen, this is about you, and we would like to enrich ourselves in interaction with your journey so far. And for the audience, the interaction will be an interview format where we will be, asking questions to her, and she's going to answer her. So there is no presentation as a, presentation in a traditional presentation format. And Deepajit Das has raised, you can see him. So he was also a recent awardee of her travel award.
Good evening, sir. Thank you, sir, for the introduction.
You're welcome. Yeah. So, so this format will be an interview format, and we will be asking questions for her, and she will be answering it. And we have Dr. Vinita with us from Goa. She will be reporting, or she will be collecting, summarizing the interview of this. And over to you, Madam Dr. Louis Cohen. Yeah. Before I ask few questions, if you want to have any opening remarks.
Okay. Thank you so much. I'm really honored to be invited, Sandra and Dr. Pushpai Jali, all of you, and I'm honored by the awardees. It's amazing, unexpected that two of the awardees are among the audience, but thank you for this opportunity to address the Indian Association of Public Health Dentistry. I was unaware, actually, of the association and of this webinar series. So this is great introduction, and I'd be happy to share the fact that you have this large gathering, and hopefully will open up doors for other associations worldwide to contribute and to share information. So thank you. And I think, by the way, that introduction was um, really very humbling. I know lots of people think I'm the architect of this field, but there were people who came before me in this enterprise. I just built or tried to build on what they started. It was very logical. And as we get into the interview, you'll learn how my journey started and why dentistry. I mean, it was quite clear. Chandra's quite right. I knew nothing about this field at all. I never thought about it. And in fact, I had very little training in the sociology of health, even. Had some, but some exposure, but not much.
Okay. Thank you so much. We will begin our the interaction with you with the first question. This question number one. You are a sociologist. Never asked a patient to open the mouth. Your influence on dentistry or oral health has been tremendous. And you have created a career path for social science analyst in oral health. And I and also few of the colleagues in my association have followed the same steps in the career, and some people are trying to aspire for those career. Now, why dentistry and why not other field? And what because if you look at the other fields, maternal and child care, infectious diseases, or so many other things required social sciences, because determinants of those diseases are social in nature, a behavior in nature, a tobacco as such. So what made you think in 1964 to start the journey in dentistry is the one which we would like to hear from you.
It was all a big accident. You'll be surprised. You may be surprised to know. I had just finished my PhD at Purdue and followed my husband to Bethesda, Maryland, a suburb just outside Washington, D.C., as you know, because you spent time here as well. And I was looking for a job. He had been recruited to a job at the National Institutes of Health as a research immunologist. And I needed to look for a job. So one of my major professors at Purdue University had a colleague in the National Institute of Mental Health, a natural, wouldn't you say, as you indicated. Mental health is, in fact, they had a lab of socio-environmental studies, an intramural lab. So I went to interview there, and they didn't have any openings, but interestingly, they said that a small group from their lab was asked to go over to another part of the public health service, the Division of Dental Public Health and Resources, in another section of our then called U.S. Department of Health, Education, and Welfare. And they were starting a social studies branch. And lo and behold, it was in the dental area. And would I go and talk to them? Because they're located just down the block in Bethesda. I wouldn't have to travel too far. And so I went over there for an interview, and it was all very interesting. They had an opening. By the way, that branch had already on board sociologists, social psychologists, psychologists, biostatisticians. They had political science represented. They even had medical anthropology in that branch. And why did they have it? Because that unit in dental public health and resources was charged with many functions, including getting the United States covered by optimal levels of fluoride in community water supplies, advocating the early detection of oral cancer, building the capacity for the oral health workforce, building new schools. We had an extreme shortage in all kinds of health professions at the time. And the dental people were supposed to be planning and making projections of where should new schools be located. And all of these areas required expertise of economists, demographers, all sorts of expertise that were outside of the traditional fields of those health professions. So that's why in the dental area, there was such a thing as social science branch, social studies branch. Now the vacancy I was asked to consider was dealing with the subject of early detection of oral cancer. Well, today we try to look for oral cancer, especially in India, where you have this issue. But in the United States in 1964, very few dentists were looking for oral cancer, even though it was a problem. Why? Because dentists up to that time were treating hard tissue. You called it dentistry is a materials profession. Well, it may be more than that, as we've learned. It's dental, oral, and craniofacial health, and the mouth is connected to the rest of the body. So we have to look at more than the hard tissue. We have to get dentists looking at beyond the hard tissue. And in those days, in the United States, they were not really being trained to look at the hard tissue. So you'd say, okay, we'll put some money out to incentivize the public health departments to test for this and to work with their dental schools and their dental associations to encourage dentists. At that time, they were using a cytology test. There were problems with the cytology methodology, but that's another matter. The fact is that before I came, they spent 4 years and many millions of dollars throughout the United States to push the use of these cytology tests. They were being used while they were being promoted, but as soon as the money dried up, they stopped being used. So they needed people to figure out why. And that's why some of us were recruited, and we started to do studies of dentists taking up that innovation and why they were hesitant. It sort of reminds me now of vaccine hesitancy that we're faced with these days. There's certain parallels here, but not completely the same. But we did that research and came up with some of the barriers. As I already said, some of it was not being taught, but aside from not being taught, it goes really back to what the kinds of people that were being recruited to dental schools. People who were being recruited in those days were really resisting looking at life-death issues. They wanted a 9-to-5 job that dealt with the hard tissue. They could go diagnose dental decay, fill the teeth, and go home at 5 o'clock and set their own hours. They didn't want to deal with life-death issues. They avoided that. So they were resistant. And by the time they did look at soft tissues, it was almost too late. They referred it to for biopsy, and by the time that happened, it was too late for the patient. So that was another thing we had to deal with. What kinds of people were we going to be recruiting to the oral health workforce, to these new schools that were developing? So it had all sorts of ramifications. And then it led to other kinds of research. How do we disseminate information about innovations to user communities in an effective way? That was outside the scope of traditional dentists to research at the time, and even traditional dental public health researchers. So that's why they called on other sorts of expertise. And why people weren't voting for community water fluoridation? What were the decision-making processes? We needed political scientists to do that. Then predictive models of where to locate oral health training facilities, institutions, and then what happens in assessing performance of dental students and the like. There are quite a number of subjects we were asked to look at. And that I know it's just the tip of the iceberg, but that's why the US government had this branch located in the Division of Dental Public Health, which was later absorbed, by the way, in various reorganizations. Why it was absorbed into the National Institute of Dental Research, which has changed its name in the late 90s, 97, 98, to National Institute of Dental, Oral, and Craniofacial Research. So that's why, Chandra, you were in that NIDCR for that residency experience.
Thank you so much. I think you're trying to say how there is a blending of the hard tissue with soft tissue, or I say the hard tissue of dental tissues. Dental, cranial, facial means all are hard tissues, but requires connected with soft disciplines like social sciences, and how it was relevant at that point of time, social sciences to further advance in prevention, promotion of health.
Mm-hmm.
So let's go to the next question. Quoting from the Mary Otto Steed, the growth of dentistry has been independent of medical field. Although this division is sometimes artificial, the cut has been penetrated much deeper than one can imagine, especially in integrating oral health with general health. What is your experience in US in this area of focus? While US had many strides in achieving some advances proposed in those documents, particularly in the area of prevention of oral health monitoring and in many other areas, integration of oral health with the rest of the system, it's again, we have a divide there. So we have a dental insurance and we have a medical insurance. You have dentistry, separate field from the rest of medical field. Perhaps one of the reasons what might be argued that organized professions choose dental services be considered separately, or is there any particular reasons you feel that why we are divided so much, even though body, the oral the organs are not divided, and we are unison there, and it has no borders.
That, by the way, the book by Mary Otto is a wonderful book that I recommend. It's really a history of how dentistry evolved in the United States, which unfortunately reflects the separate nature apart from medical school. The question originally arose, University of Maryland, not far from where we are, but I am in Bethesda near Washington, D.C., in Baltimore. that's where the first accredited dental school in the United States started. And there was a question of whether dentistry should have been co-located in the medical school. But for whatever reason, whether the physicians rejected that notion or the dentists wanted to be separate, it's still a bit controversial there, but it did grow separately, as opposed to Europe. If you look at the history of dentistry in Europe, it grew as a subspecialty of medicine. Stomatology was a subspecialty of medicine. And some say we should have used that model. But instead, what has happened is that the US model, where the dentistry was siloed apart from the medical model from the very beginning in health professions education. And therefore, it got siloed in practice. And often what innovations happened in medicine did not spill over till dentistry. And sometimes if they did, it happened later. And you mentioned insurance. For a long time, when I came in the field in 1964, there was a trace, hardly any insurance for dental coverage at all. There was private medical insurance, not a lot, but hardly any dental insurance. We had a unit in our division of dental public health that was looking and trying to grow the field of dental insurance, but it wasn't even there. So innovations in medicine were separate from innovations in dentistry. And that was a sad statement. I personally thought, sociologically looking at the European picture, that we made a mistake there, but so be it. That's the way it evolved in the United States. And then later on, the US model became so dominant that it really permeated other parts of the world. And as you know, that's really what's happened in the Asian continent as well. And after the EU started in the European continent, the EU made a decision to go with the US model as well, and changing from the schools that had trained subspecialist stomatologists to our system. Even though it's still different in the sense that we have 4 years of undergraduate university training before going to dental school, and the Europeans go from secondary school into dental school. That's a slight difference, but it still grew separately, unfortunately.
Yeah. Yeah, I understand that. I think most of the US dentists or US dentistry wants to be separated because they have their own independency. But now we are struggling back again to integrate medical and dentistry, because we want to now to look at, we can't have a vertical programs for the prevention or promotion of oral health. So we know that how it is, it's not a rational approach, or ethically it's not correct again in a public health practice. And now we know that even though there was, we don't know why it happened, why we are divided. Now we are trying to look at, even though we grow differently, we look at the patient care, we need to have some sort of integration, and that makes the promotion of especially a periodontal health, better.
Yeah, I just would add another thing is that dentistry for a long time resisted being part of, in this country, as part of some kind of national health program. But you see a change in organized dentistry now. They're actually making advocacy moves to try to get dental coverage under some kind of our national programs, expanding Medicaid for those disadvantaged to include dentistry. It is for children, but now possibly for adults, and for Medicare for those elderly seniors in our population. And we can explore possibly why that change has occurred. It may be because they're not getting reimbursement that's equal to what they are used to getting with private fee-for-service, and maybe trying to negotiate higher levels of reimbursement. I mean, lots of possible reasons why that change has occurred, other than realizing that the mouth is part of the body and maybe it is time to reconnect.
Yeah, you rightly said, telling that we need an integration rather than medicine needs the integration with dentistry. Though their spillover is very less rather than we get spillover over them, actually. Right. So question number 3, going back to the advocacy in this regard, how can one involve in oral health advocacy? Because you are being in forefront of being a non-dentist, but still in a oral health advocacy in various organizations. I don't think there is any organizations where your footprints are not there. And you have been in a co-director and director of WHO collaborating centers and large studies you did. So what are your lessons learning from an advocacy viewpoint of view from the local to the global level? And does the international level of advocacy, say in that UN political declaration in 2012 regarding NCDs, where oral diseases, oral eye and mental disease should be there in the part of NCDs, and how far we are able to progress toward this side from your perspective?
From my perspective, of course, I started out working in the public health domain. So I naturally think about the public because I work, and I started to work in the government, and I continued even post-retirement to stay consulting with the government. But that brought me to have to work with the dental education sector and with organized dentistry, and to other segments in the dental world, even with the dental industry, with either personal products industry, dental materials industry, health promotion, health information industry. But what I'm trying to say is, in my journey, in my career journey, I've noticed that the weakest form of advocacy, the dental educators advocate for more benefits for dental schools or oral hygiene schools, or resources for the oral health workforce, whatever they're called in their respective countries. They have advocacy for their professional turn. The same with organized dentistry. They have advocates. But civil society, what we call civil society, representing the public, hardly find groups that advocate. Now, we have American Cancer Society, or Association for Juvenile Diabetes, or the Association of Patient Support Groups for Ectodermal Dysplasia, or you can name the American Heart Foundation or association. All these patient groups that go and advocate, in our case, to the US Congress for more resources for research or for public programs or reimbursement in their areas. Who goes from the dental group? We had to help organize, if you will, a patient advocacy group in the oral health area. It's very, very thin. And there is something called the Friends of the National Institute of Dental and Oral Craniofacial Research that does go to Congress. They're very effective. They are the patient support groups, the diabetes groups, the Sjogren syndrome groups, the cleft lip and palate groups, the epidermal dysplasia that will go because they have oral manifestations. They will go and advocate for increases in our budget. But globally, we really are lacking in civil society. Now, you mentioned the UN General Assembly has come out twice. Well, actually, they've mentioned health only recently in this century. The first suggestion General Assembly, other than establishing the World Health Organization in 1948, post-World War II. Health was really pushed high on the agenda when HIV/AIDS came on the scene. In 2001, they made a declaration about that. But in 2011, it was the second major time they spoke about health. And it was the first time that oral health was included. And it was on that UN political declaration on the prevention and control of non-communicable diseases. And they added a line in section 19 of that declaration to include oral and renal health, and later they added and eye health, and later they added mental health. Well, I would say they misnamed it. They call it non-communicable. It's really chronic diseases, but they still call it non-communicable diseases. And they named those as heart disease, cancer, respiratory diseases, heart, cancer, respiratory, I always forget one. At any rate, they have common risk factors, and the risk factors are the common diet, alcohol, tobacco, lack of physical exercise, for example. And here, oral diseases interact with those other diseases because they share common risk factors. And that is why oral health today at the World Health Organization, WHO being the public health arm of the UN, that's why oral health is nested within the NCD cluster, the non-communicable diseases cluster. Importantly, in 2019, pre-COVID, the UN's second mention of oral health came about when they had a political declaration with respect to universal health coverage. And oral health was again included to be integrated into that declaration. Then, this past May, at the last week in May, when the World Health Assembly met, 194 member states voted to approve an oral health resolution, raising the level of visibility of oral health in WHO and allowing for a new oral health strategy to be developed to integrate formally our oral health interventions within the umbrella of non-communicable diseases, those chronic diseases, as well as universal health coverage. This is very, very, very important and a major milestone, maybe even a tipping point for oral public health. And this just happened at the end of May during this COVID pandemic. So at the present time, we're in the process of witnessing the development of an oral health strategy, an implementation plan, hopefully for next year, and looking forward to some strategic goals and metrics that will measure our progress, both process and outcomes for making global oral health a reality for in population health. So advocacy is very important, but written into this is civil society's role. And yet we have very weak capacity in this area. That's the weakest link in my view. And we have to really work hard to build a momentum to try to persuade the public, the population, that they should be aware of the mouth is attached to the rest of the body. It's important, it should be integrated, and there should be coverage, health coverage, for the mouth and supporting structures.
Yeah, I think that what we are lacking is the champions in oral health, so that we need those stories to tell them about policymakers or policy community about how, and we need champions and activism role to propagate further, right? Okay.
Right.
So I invite Dr. Pushpanjali to continue with the question number 4.
Thank you, Dr. Chandrasekhar. It was indeed a very interesting conversation. I really liked your viewpoint on advocacy efforts from patient groups. That is something that we need to explore and try as to how best we can look at that and initiate that process. Probably we'll discuss and take some more points about that a little later. And before I move on to question number 4, let me congratulate the 2 recipients, which I was not aware of. Dr. Das and Dr. Chandrasekhar, congratulations. You made us proud. Very nice. Madam, now moving on to question number 4. Now, could you briefly tell us the prevailing conditions in the 1970s or the factors that led to the conduct of the WHO and United States Public Health Service Commission Corps International Collaborative Study of Dental Manpower Systems concerning oral health status? Would you say that oral health has improved across the world or degraded? And what has been the impact of this study? How did this study change the oral health status of the world?
Thank you for that question, because that's really the question that got me into global health. Up until that point, I was looking at questions in the United States, issues and problems in the United States. Well, under President Nixon, he had to, believe it or not, opened up our system to relationships with China, if you recall. China was closed and we had no relationship, no official diplomatic relationships. He gradually was the one that opened up a lot of our international dialogue. And in that, he also was one of the first presidents. These things are not, not that I voted for him, I did not, I admit, but he proposed a program for national health insurance. He didn't get it passed, but he did propose one. And here we were sitting as federal employees and saying, well, what's going to happen with dentistry? Is it going to be part of this proposal that the president is making or not? Well, the only thing that we had in the United States was private practice fee for service. As I mentioned, we hardly had any dental insurance at all. So what were we going to look at? We couldn't find any answers by looking in the United States. So it was quite natural to look outside the country for possible solutions for what could be proposed. How should dentistry be integrated into some proposal for national health coverage? So we approached, and this is truly very interesting, our chief dental officer was John Green, a periodontist, who developed the oral hygiene index. Some of you know Green and Vermillion. Well, John Green was our chief dental officer, and he was very much concerned about this issue, and he liked the idea of looking outside the country. But this was during the Cold War. We were in a Cold War with the Soviet Union, and a lot of the countries we needed to look at were possibly behind the Iron Curtain. So the ones that we thought had dentistry covered by some kind of national health program. For example, what Lyndon Johnson had started in the Great Society. When I came on, President Lyndon Johnson was the president, and he started something called the Great Society. That's when we started neighborhood health centers in disadvantaged areas. Well, those neighborhood health centers were really a prototype of what was happening in Eastern Europe. They had polyclinics that covered everybody for all their health services, one-stop shop for all of your health needs, including oral health. So anyway, getting back to John Green, he approached the chief dental officer of the World Health Organization, who happened to be a Russian citizen, national. And so we didn't know how that was going to work. But Vladimir Rutko, who was the chief dental officer at WHO at the time, very progressive thinker, liked the idea very much. And when you're an employee of WHO, you forget your you're supposed to forget your national credentials and think globally. And fortunately for all of us, he did think globally. And he was a very strong partner in agreeing that we should look globally at all systems that had a kind of national program and look for the structural characteristics of those systems to see what might be working most efficiently and effectively for the respective population. And we should share that information, not just use it for the US, for example, or for Russia, or whatever, but to share it on a global platform. So he appointed his epidemiologist, who was David Barnes. David was the oral epidemiologist, an Australian national who did his dental public health both in Queensland and Australia, but also at University of Michigan, had many years of experience in Papua New Guinea, and he went to Geneva and spent his career there. As we all know, David progressed throughout the WHO organization, but in the late 60s and early 70s, David was the oral health epidemiologist. So Vladimir Rutko appointed David as his point person. John Green appointed me as the US point person, because he felt that we had to examine oral health delivery systems, not just from a clinical epidemiologic point of view, but we needed somebody that knew how to measure health system factors, structural characteristics of health systems, both process and outcomes of health systems, social systems. So that's why we had this kind of match between oral epidemiology and social sciences. You might call it socio-dental sciences. And so we formed this co-investigator bridge. And we got together and developed with a whole series of global consultants. We had Aubrey Shyam from the UK, periodontist, obviously a great public health leader. We had health systems people from WHO, health economists from Michigan, Paul Feldstein, I remember. We took caries specialists, perio specialists, oral cancer specialists, all kinds of specialists, brought them to Geneva, had a technical advisory committee, and started the process of doing a common research protocol. One protocol that multinational teams in each country would be teams that were interdisciplinary. They had to be interdisciplinary. They needed to match the protocol. And we wound up after 2.5 years of planning. The US put up money for a planning grant. And it took 2.5 years in those days because we were using airmail. We didn't have digital communications. And even telephone was not easy because we had to get special permission all the time to make long distance transnational phone calls. It took 2.5 years to put this together and many meetings. And we had the common protocol and we had to pre-test the protocol in countries. We had to select the countries. This team put together the criteria for country selection, and they ranged all the way from fee-for-service at one end of the continuum all the way to government-funded service for everybody. And we had countries ranged from US and New South. We took areas within the within countries, by the way, that were highly functional, but not capitals. We didn't want the capitals because most countries put most of their resources into capital cities, and that area of the urban and non-urban hinterland. So we tried to use another, probably the second or third city, and it's non-urban hinterland as the sampling area. We use common sampling criteria for each and pre-tested the clinical indicators as well as the interview and questionnaire. And it had over 30,000 respondents, 3,000 in each country of population, age groups. I'm sorry about this. And provider groups, 100 each of the provider groups plus administrative data. So it was the largest study of its kind ever done at the time. And that's why it started. We wanted to know what, we didn't believe that you could transplant a system from one country to another. We didn't believe in that. What we thought we were looking at were structural features of those systems that seemed to be associated with optimal outcomes for the population, good health indicators for the population. And that's what we were looking for. So we weren't looking for total systems, just key features. So we did find some unexpectedly. We were looking, by the way, for manpower. In those days, it was called dental manpower because we didn't have many women over in the US anyway who were in that workforce. Today, we would not call it that. But from another point of view, we were also biased in looking and assuming that it was the workforce that was key. We were sure that the more that you amped up the workforce, especially in shortage areas, the more people you had to work on a problem, the better the outcome. That hypothesis failed. It didn't work. It didn't pan out anywhere. That the more available, accessible, and affordable that workforce was, the greater the health of the population. Didn't work that way. It had more to do with consumer acceptability of system characteristics and prevention. And prevention may have not been always in the hands of the workforce. It could have been community-based. So we were looking at workforce models like in New Zealand, we looked at the dental nurse. That was in existence from the time of after the First World War, when you had to bite the bullet. And because the military couldn't bite the bullet, they put dental nurses, 2-year trained auxiliaries, into every school system in the system in New Zealand. We also looked at Germany. Germany had dentists with very few auxiliaries, practically none, but they had a very advanced social insurance fund system, the Kassen system, that was in existence since Bismarck's time. So we looked at that system. We looked at Scandinavian system, and we chose Norway that did use auxiliaries, had a school-based system, but used full trained professional dentists as well as auxiliaries, and had a private practice model for adults. So we looked at a variety, including East Germany as a comparison to West Germany. East Germany had polyclinics, service, one-stop shopping for everybody, and a lot of prevention, by the way. So you ask, what's the impact of this study? Well, we didn't get any kind of national health insurance, as you know, from Nixon's administration, or until President Obama did we get any semblance of this. And oral health is not necessarily part of that system now, but we learned a lot, and some systems benefited very much from the experience of self-study, because they had teams in each country. Sorry, this thing keeps going. Let me see if I can. It's my telephone. They experienced it. We left data sets in each country, and a duplicate set went centrally. So every country rolled out their data and did their analysis right away. And some of them did it before we could do the global analysis. So that was one thing. The other thing was that some countries didn't have oral epidemiologists. They didn't have public health dentistry. And so they had to train people to do that work. They didn't have social scientists with any background in dentistry. So they had to recruit some social and economic scientists to come in and help them and train them so they had some oral health experience. So that was a boon. And so you see in many parts of the world now where we were operating that study, 10 countries were involved in the first one, and we repeated it and had more countries in the second. So you will see now some of this expertise is homegrown, and they are engaged in this kind of research. So that was a spin-off that we didn't quite plan for, but it was great that it happened. There's more capacity building, in other words, in some places. So some countries tweaked their system, and New Zealand was one of the first, because while they were really pioneers with the dental nurse, they also found that the way they deployed dental nurses, they gave them quotas of how many teeth to fill. That didn't bear much relationship to population health. Sort of a non sequitur, if you will, between what that population needs were and what they were expecting of those dental nurses. And then the public health dentist went around, did a circuit of all the dental schools and of all the school dental clinics to make sure those dental nurses were meeting their quotas. They didn't know that before. But some of the positives that came out, things that we learned were that where there was water fluoridation, where the prevention was there, and even Norway where they didn't have water fluoridation, but they had fluoride, they were using fluoride, that's where we saw benefit. The other thing we found out was the US sample and the West German sample looked pretty good when you looked at aggregated data. But when you disaggregated the data, the US, for example, came out looking pretty terrible. The discrepancy between the best off and the worst off was the widest. In other words, we had health disparities. We didn't know that before. We were looking at aggregated data. When you look at the mean, everything goes toward the mean and looks pretty good. When you disaggregate the data, you can see the discrepancies between the best off and the worst off. So that's another thing that became apparent. Health inequities were disclosed. And of course, we see this with COVID. We know this now, many decades later. We're much more aware of this than we were in those days. So we've come a long distance from the 70s in knowing what to look for. But we were pretty naive in the 70s. And I was sitting in a division of dental public health was nested in a Bureau of Health manpower. That's why we were looking at manpower, because we all assumed it was the workforce that was determinative. Yes, the workforce is important, but it has to be matched to the population needs. Everything has to be gauged against what the population presents. And you can't always, the other thing I want to mention is that we realized very early on and designed the protocol this way, that you don't compare one country to the other in absolute numbers. You have to look at the outcome in terms of their own population needs, their baseline of where they start out. Because some countries, especially in the lower and middle income countries, sometimes their oral health is not bad. And they only get worse when they get into the urban areas and become highly industrialized, starting to eat junk food and lots of sugars, etc. So you have to be careful knowing the population baseline. So what we're using as an outcome was services over need, a measure of, for example, D over DMFT, just as an example. So you look at need, but you look at, or treated over decay. Okay, yes. So services over need became a ratio, and that's how you compare one system with another. That's another thing, a lesson learned. It's relative to the population that you're dealing with. And even within a country, we should be looking that way, because our countries are large and our populations are not homogeneous. You know, so we have to be very cognizant of those differences. And in India, I remember early on in visiting India, the differences in fluoride, endemic fluoride in different parts. So your population is naturally exposed to different kinds of levels of fluoride. And some areas, of course, need defluoridation.
Thank
Anyway,
you,
I
Cohen.
could talk for an hour on that, on this study, but I won't, unless you are interested in a particular aspect. But thank you for that question.
Thank you, Cohen. That was a very elaborative response. You took us through your process of your journey, and you also introduced again David Baines, John C. Green. So we went back to those times, reading about them in the textbook. Now we got to know the real contribution. Thank you very much for that. And also speaking about the importance of denominators. Finally, that is important with respect to each country, and sharing your, the major study that you did across the country, your journey for 2.5 years, finally in the protocol. That was wonderful. Now, moving on to the next question. Now, bringing oral health into discussions at par with oral health issues has been a challenge. Again, quoting you, such circumstances represent a double burden of failure to recognize a social problem when documentation for the oral social problem exists. What do you think should be done to advocate for oral health at several levels? Probably you take this question and then we will move on to the next question.
Well, I think I spoke to the need for documentation clearly, that and the way I was my experience in the health policy area, I learned a lot from one of our former and late assistant secretaries for health and surgeon generals, Julius Richmond, whose work in health policy elaborated that health policy is the confluence of three things: evidence, research evidence, social will, and political will. You need three things to come together. So you must gather the evidence around what you think is going to work. You have evidence that it does work. I mean, WHO is calling these things best buys. And one of the challenges with the oral health resolution, or the products of that exercise will be, is to come up with best buys. What are we going to recommend to countries? A menu of best buys. They have to be research evidence. The second we've talked about already is the role of civil society, getting the public to want this. If they don't want it, they won't drive their politicians to do a thing. And the politicians only do what the advocates want. So it's three things coming together. I mean, it's sort of simplistic, but we have to keep reminding ourselves that we need those three things to come together. And very often we work on them separately, but we don't try to take the results of our research and bring them to civil society, to mobilize then civil society with that information, and then take it to the next step, to the politicians, to make changes in health policy. So it's those three things. And then we have to think it at the local level as well as the national and at the global level. I mean, at the global level, it was interesting that civil society organizations like Doctors Without Borders and the cleft lip and palate community came to speak up on behalf of that oral health resolution. That was very powerful for us. not only the two organizations that have formal relationship with WHO, there are only two in the dental field. That's International Association for Dental Research, IADR, and the FDI. FDI representing organized dentistry. So FDI spoke and IADR spoke, but importantly, so did some members of civil society. And the Non-Communicable Disease Alliance is very much an important emerging new civil society alliance. And that group I'm very enthusiastic about, where the four major non-communicable disease groups have driven, but are including other chronic diseases under that umbrella, and trying very much to advocate for the common risk factors and doing something about mitigating those common risk factors, tobacco control, alcohol control, decrements in sugar consumption and sodium consumption.
Okay, that's really very interesting, Dr. Cohen. You're emphasizing on civil society taking the lead. That is something nice, and I think we should be working towards that. Can you? I know I am trying to deviate from this. I just want to get maybe a single or two lines. How do we initiate such an action? How do we ensure that our civil society also takes such a role? Do you have something to say, or should we come back to you a little later?
Well, I mean, it's not an easy thing, and you have to look within your own countries. I know we, at NIDCR, for example, when we were changing our name, and that's when the patient groups, we needed patient groups to help. That required congressional language to be changed. So there were people from these patient support groups that were very concerned about the kinds of research that we did in the Institute. So they were coming to us periodically to advocate, and they decided to organize themselves into the Friends of the IDCR. So you have to look at each situation. Years ago, I remember that there were occasional community-based groups around advocating community water fluoridation, because in this country, it was a political decision that with community referenda and public votes, some jurisdictions had, you could do it by city mayor could, do an administrative action. But in many situations, it was community referenda, because a lot of the water supplies were run by 13, 20 different water supply companies. So it across different jurisdictions. So they all had to have all those communities had to have a vote. So we had some community organizations form around that. So you have to look to see in your own environment what the community is concerned about and leverage them.
Correct. Thank you so much, Cohen. Moving on to the next question. Dr. Chandra, would you focus the question, share the question?
Yeah,
Chandrasekhar?
Yeah,
Yes.
I'm doing.
Yeah. Are you taking this question, Dr. CJ?
No, you can take. No, it's
Okay.
not
Is
a
it
final.
the final question?
No, it's not a final question. We have still more to.
Yes.
Yeah.
Madam, this is for you. What would you like to advise our young dental public health professionals and students among the audience who might be interested in taking the social sciences path in dental public health?
Well, that is a good question, and I'm not sure I know what is in your curriculum now. I mean, some schools here, for example, have social science integrated into their public health community dentistry curriculum. Not all schools have that. And so that is, I'm really not familiar with what exists in the Indian context. But if you're in a situation where you haven't had exposure and you want exposure, there's several ways. If you're able to take courses in the sociology of health, the social sciences, behavioral medicine, it depends which aspect. I mean, social science is a broad field. And as Chandra mentioned, that book, Disease Prevention, Oral Health Promotion, came out in the 90s. It was preceded by 2 volumes, Social Science and Dentistry, Volume 1, and Social Science and Dentistry, Volume 2, which brought together different fields from psychology, social psychology, as I said, political science, health economics, medical anthropology, and brought all the literature together up until that point. In the 90s, we brought it up, sort of state of the science reviews up until that point. So reading is one thing, but going and taking some courses in that aspect of social science that you're interested in is another. And then if you're in the situation where you have a research question, that you're engaged in active research, and you really can't go back to school and get a PhD in the other subject area to add to your own credentials, is bring people into a research team. These days, we don't do research by ourselves, as you know. We do interdisciplinary research teams. So bring in colleagues from those social sciences, as we did with the developing the Common Research Protocol for the WHO International Collaborative Studies. We had to develop a research protocol, but with different skills. We couldn't, I don't know how to ask the economic questions, so we had to bring in an economist to know how to do that. The epidemiologist to know what clinical indicators to probe for, etc. So you bring in those sciences into the research team environment to craft a common research protocol. And together you actually increase the viability of having something transdisciplinary, not only interdisciplinary, but some product comes out that you never thought would come out that's sort of over and above interdisciplinary. It's sort of brand new, transdisciplinary look. But for young scientists, pursue the research question that turns you on, and then go backwards, work backwards to say, what skills do I need to answer that kind of question? And take a course or two, enough to know maybe I need some more expertise in this, either go further and get the degree. And some of our people do that. You know, we had training grants. We had 2 kinds of training opportunities from the government, where we gave grants to schools to train people in these multidisciplinary fields. So I remember we had a training grant at Columbia University School of Public Health to train sociodental scientists. We had one at Harvard University, in health education, health promotion. We had one at University of Pittsburgh, as you remember, to train dentists in educational sciences, educational research. That requires two. And one is social psychology and behavior change, individual change. So we had training grants, and then we had fellowships where dentists could go for postdoctoral research fellowships to get this kind of training. So that's another kind of advocacy if you don't have those kinds of opportunities to advocate for research training support for these kinds of opportunities, or apply for these grants from different, multinational foundations or funding research sponsors for extra training. I hope that helps.
Yeah, I think, Madam, are you there?
Hello.
Yeah.
Hi, Dr. CJ.
So,
I think I have, yeah, go ahead.
I think you were frozen for some minutes.
Yeah.
Yes, there was low connectivity. I'm sorry about that. Dr. Cohen, thank you so much. I think you very subtly indicated that multiple skills are required, and as and when required, we have to go and train ourselves and come. Search for possibilities wherever, whether training or wherever funding is available, but keep on learning. Be a lifelong learner was the message, I think, that was very clearly mentioned. Thank you so much, Dr. Cohen. Dr. CJ, can you please take over now?
Yes. We have a lot of questions to ask, but to do the time, some of the important questions were taken. And I would like to hear some questions from the audience if they want to ask directly to the Cohen. So if anybody, audience can on your video and unmute yourself and please ask questions.
You can raise your hand.
Yes, Ram Prasad.
Yes, sir. Thank you. Yeah, thank you for the opportunity, sir. Just two small queries. Thank you so much, Dr. Louis Cohen. A wonderful presentation, a very insightful presentation, which added a lot of value to our understanding. Sincere thanks to you, madam. A real informative presentation, as well as thanks to the team, IAPHD, for this particular platform. Wonderful thing. I had two queries in mind. Madam, we are at a state where we are actually developing public health dentistry, and it's going well in our country right now. We are seeing how best we can connect and collaborate with other organizations and alike. But in this context, intramural and extramural research, any thoughts on developing intramural and extramural research in our country? One. And second is the concept of dentist scientist is coming up nowadays. In the sense, a lot of collaborations as well as deep commitment to research in dentistry and dental public health is the need of the decade. So how do we address these issues, intramural and extramural research and development of a dentist scientist? In the sense, dentistry is getting into deeper zones nowadays. And in the coming decade, I'm sure we'll be going even deeper into other aspects which will actually add value to the oral health related quality of life, which we are all addressing. So intramural and extramural research, collaboration and development, as well as the dentist scientist. So those are the two queries which I had in mind. Thank you so much, Chandrasekhar sir. Thank you so much.
That is a question I think you directed to your Indian colleagues. Yeah. Because we in the United States, did start intramurally. And then we had grant programs extramurally. And now we mainly do it extramurally. But that's from the funding agency point of view. But you're talking about in schools? In dental schools.
Right, ma'am. Actually, yeah, because we still don't have a very clear understanding of intramural research and extramural research and how it can actually be developed So we're at 2021. So this decade, if you're looking at intramural and extramural research, what are the suggestions and recommendations from your experience, and how do we cultivate and how do we nurture the dentist scientist concept? Those were some thoughts and some insights from your side, very helpful.
Again, I'm not sure to whom that question was addressed.
Yeah, I think I can take that question.
All right, right, sir. Yeah,
Ram
thanks.
Prasad, that intramural, extramural comes to within an organization. Like if you see an ICMR, if you are
Right.
if ICMR scientists will those who are working in ICMR can intramural research, and extramural is those who are outside the ICMR, then can apply for those ad hoc projects or the call-in applications for the research funding. So that's what the context which Dr. Cohen was able to appreciate that.
Right. Okay.
Okay. Is there any other questions from the audience?
I wanted to just mention that I came across something recently on about our U.S. Congress that I thought was so interesting. They have just recently formed a caucus of Congress people interested in social determinants of health and how to tackle that. And I think that is going to be very useful, not only for major health issues, but specifically for any subpart of the research community that wants to look at social determinants. I think most people, most funding agencies, and I imagine ICMR is like this too, has budget line items for certain parts of the body. But these horizontal cross-cutting issues like social determinants of health that apply to everybody, these are important, and we need to be aware of how to tap into those resources. And so that was very encouraging for me to see that the Congress themselves looking at these cross-cutting issues.
Yeah, I think there are no further questions from the audience. Maybe it's 8 o'clock in the evening here. So
Yeah.
maybe there are butterflies in the stomach, so which is causing them to stop the questions. But thank you so much. I'm going to summarize your what we had a discussion with you. It was a pleasure hearing and learning from the architect of emergence of social and behavior sciences in dentistry. Walking us through your journey, you highlighted the need of integrating the social and behavior sciences in dentistry. And you spoke about how innovations in medicine were different from innovations in dentistry, a sad picture, but one that India also has the same pattern where we have such divisions here also. However, today we realize that oral health and general health they are connected, but still today we talk about integration at the different levels. You spoke about the need of advocacy, patient advocacy, and civil society advocacy in dentistry and for the oral health promotion. Looking globally for solutions and share information on global platform, the need to examine health systems, not just healthcare delivery options, but also determinants of healthcare situation is more important. It was interesting to hear how we are stepping up the manpower, not always as a solution. And I was really happy to hear the word how the manpower came. It's not to be used nowadays for the manpower because it's a it's a gender linked word actually. So it should be a dental workforce rather than manpower. So it was interesting to hear the stepping up manpower was not always a solution, but it should be looking at affordable, accessible, and culturally competent workforce at church. You spoke the understanding the needs of each country specifically, understanding existing health disparities, and need to look at the issues relatively and as a ratios, and also customized to the needs of the each culture or community there. Thank you so much for us. You have done, your interactions were so much enriching for us, and it is a new directions. And IAPHD as such would like to also collaborate internationally, because 130 crores, it's a 1.3 billion population who needs an oral health care. And even though we say that dental public health is the largest, gathering what we have in association, but still it's not sufficient to reach every person, a last man in our community. So we would like to also have some sort of a mutual interactions at the later stages and take it forward globally. And with the oral health resolutions at 2000 recently at the WHO, I think we as IAPHD, we would like to be an advocacy and activist role to, use those resolution and also propagate in our own community, especially in policy community in India, to implement those things in our settings. Thank you so much. And I also thank Dr. Rajiv Basapati, who was helping us to frame these research questions, and Dr. Vinita Sanjeevan for compiling for us. Thank you very much. And I will request Dr. Vamshi Krishna Reddy to make a closing remarks.
Thank you very much, Dr. Chandrasekhar, sir. First of all, I would like to thank the entire scientific committee chair under the leadership of Dr. Pushpanjali Madam, and the blessings of our President Emeritus R.K. Bali sir, our advisors, our President-elect Dr. Sabyasachi Saha sir, and all the office bearers, giving a enormous encouragement for the scientific committee chairperson Dr. Chandrasekhar to lead this, and bringing in Louis Cohen for this particular day as an opening batsman or opening person for this international webinar series. And thank you, madam, for sparing with us almost 2 hours continuously with the utmost enthusiasm and with the true spirit. And it was extremely interactive session. And I would like to thank our IT team who is behind this, and our technical people, and all the participants who are already participating, and we have gone live on Facebook also, and more than 400 to 500 people are watched this on live, and the room was so full that many people were unable to join. And next time, I think from 500 to we'll make it to 1,000 people to join it. And thank you once again for all the participants for actively participating in this evening. And we will be giving the certificates very soon after verifying your participation and your credentials. We'll be emailing all the participation certificates to you. And we will see all of you in 20th August. Dr. Habib Benjain will be joining us for the second session. Awaiting one more enthusiastic session that is going to happen on 20th August. And I request all the participants and all the delegates who have participated for the cooperating for this deliberation. And I hope the Indian Association of Public Health Dentistry will entered into a global picture. And I'm sure Louis Cohen, madam, will be helping us and guiding us, taking forward with all our scientific committee to take us into a global picture. Thank you very much, one and all.
Thank you.
Thank you. Thank you so much.
Thank
Thank
you.
you.
Thank you so much.
Vamshi, you can take one screenshot of it. If everybody can on your videos and having the smiling position, so that
may I request Bali sir, you are there? Bali sir, final words from you, sir. Madam, Dr. Bali sir is our President Emeritus, and he is the founder member, and he is the man instrumental for the growth of Public Health Dentistry Association in India. Is the legend for us. And sir, concluding remarks from your end, then we'll have a group photograph or a screenshot. Bali sir, over to you.
Dr. Cohen, this was one of the best seminars I have ever attended. It was so nice You have very good questions and answers, and you have made us so knowledgeable that we cannot forget it. Thank you very much.
Thank you.
Thank you. Thank you all.
Quite an honor.
Okay, all of you on your webcams, please. We'll have. Thank you so much. Have a great day. And namaste once again from India, ma'am. Thank you.
Thank you.
Thank you, Chandrasekhar sir. Thank you, Pushpanjali madam. Thank you, Bali
Thank you.
sir, and all the senior
Thank you.
delegates. Have a great day.
Thank
Good
you.
night.
Thank you. Thank you so
Thanks.
much.
Thank you.